Laboratory, or in short, Canres. So allow me to begin with a brief introduction of our lab, Canres. Now, Canres is one of the 4 laboratories in Institute of Bioscience, Putra, Malaysia. It was established in 2005 as a joint collaboration between UPM and Majlis Cancer Nasional, or MAKNA, in pursuit of enhancing the cancer treatment. Now, the main objective of Canres is to coordinate, integrate, and centralize all cancer research in UPM towards developing, expanding, and commercializing the research outcome in one focus and strategic management. The research at Canres focuses on 3 research programs, namely cancer stem cell biology, cancer immunology and therapeutics, and comparative cancer biology. Our researchers come from various fields, including medical, biotech, chemistry, physics, computer science, and others. Apart from research, Canres also actively involved in industry and community linkages. So for more information, please visit our website at ibs.upm.edu.my. Now, Canres webinar was initiated in 2020 with the aim to share the current cancer research in Malaysia, as well as overseas. So we hope to engage clinicians like what we did today. And the webinar will be held every 2 months. And our next webinar will be in October. Not all going to have our cancer symposium in August that only open for UPM people. So the information regarding the webinar can be obtained from Institute of Bioscience, UPM website, Facebook, as well as MAKNA Facebook. Now, this cancer webinar is a collaboration between MAKNA as well as War on Cancer, WANSI, Malaysia. All right. So today we are very honored to have our speaker, Dr. Tzveta Pokrovska. Hopefully I pronounced your name correctly. Well, she attended the Queen's College, University of Oxford, for her medical degree between 2004 and 2010, and subsequently underwent foundations and core medical training in Glasgow. She became an academic clinical fellow in clinical oncology in 2014 and completed a DPhil focusing on the synergy between oncolytic viral therapy and axonal beams radiations in 2020, supervised by Professor Lance Seymour Higgins and Dr. Janet Lay, who was our last speakers in April. So the topic for today's webinar is drawing the line, balancing killing the cancers and protecting the patients in radiotherapy treatments. So without further ado, before we start, if you have any questions, can you please type in the chat box? We'll read your questions towards the end during the Q&A sections. So without further ado, Dr. Tzveta Pokrovska, the screen is yours.
Thank you very much, and thank you for inviting me to speak today. So indeed, I'm a radiation oncologist. I've been a radiation oncologist since 2014 now, and today what I thought I'd do is start quite basic to talk about what radiotherapy is, essentially the different ways in which it's given and how it works, and then move towards the overarching themes of what we're currently looking at, specifically mostly in the UK, though some of the trials mentioned are international in terms of the way that we're working towards, and primarily that's trying to balance the toxicities of radiotherapy and the long treatment regimes that we use with trying to get rid of the cancer and making it better for the patient and also for the health services. So just to start off, what is radiotherapy? Most people will be familiar with the concept of radiation and will have come across radioactive materials being mentioned, such as uranium and radium and things like that. And there's many different types of radiation that are emitted when radioactive materials decay into a more stable state, which is how it's released. However, most of the radiotherapy that is used in patients is primarily photons, which is not in fact something that's done by having radioactive materials emitting radiation, but is very high energy X-ray beams. And the way that the high energy X-ray beams are produced are by heating up some tungsten, producing electrons, accelerating them down a linear accelerator or a LINAC and firing them at a target. And the interaction of the electrons with the target then results in these very high energy packets of X-rays being released, photons, and the photons are then targeted at the patient. So what you can see here is essentially, this is where it would come from. The patient would lie here, and this would be moved around with a high energy X-ray beam focused on the patient. And the important thing about this, of course, is that unlike things like chemotherapy or immunotherapy, which are the other types of very common treatments that the oncologists use, radiotherapy is very, very concentrated just on the area that we want to treat. So it's a very high energy X-ray beam, and it's focused on specific areas that we want to focus on. And it's used for many different reasons. And actually, about 50% of cancer patients will be having radiotherapy at some point in their treatment pathway, whether that be to try and cure the cancer, get rid of the cancer, whether that would be to either make surgery work better, known as neoadjuvant radiotherapy when it's given beforehand, to try and sterilize the area that's been operated on and mop up any potential little cancer cells that we might not be able to see after surgery. Adjuvant radiotherapy is a very common use, or whether it's with the aim of what we call palliative radiotherapy. And palliative radiotherapy is focusing the high energy X-ray beams on an area that we want to treat with the aim of helping our patients. We're not aiming to get rid of the cancer, but we are hoping that the radiotherapy beam will lead to shrinkage or control of symptoms. And it works essentially on the subcellular level. So I know we have a very big range of audience members here. So just a very, very quick picture of the cell. Now, if you imagine the high energy X-ray beam being focused on the patient, it's going to have an impact throughout the tissues because it's coming in from the outside, it's coming out from the out, and it's coming out through the other side of the patient. And on its way, the way that it's going to work is it's going to deposit the high energy X-ray beams in the tissues that it goes through. And that energy deposition is what leads to the effects that we see from radiotherapy. And as it deposits the energy, it will cause damage to a number of areas in the cell. But most things in the cell are there in multiple copies and are repairable and can be made again. But the one thing that isn't there in multiple copies and isn't easily repairable, but is most of the time during the cell cycle available as just 2 complementary copies, is the cellular DNA. And so what radiotherapy does is it's believed to primarily act on killing the cell by causing damage to the cellular DNA. And if enough damage is caused, or if the damage is serious enough, when the cell then tries to replicate, it dies off instead of being able to replicate. And the reason the DNA is so important is, as I said, because everything else is there in multiple copies, it's easy to repair, except the DNA, which isn't there in multiple copies. If you cause enough damage, in particular, if you cause a break through both strands of the DNA, enough of that is what tends to lead to cellular death, and that's what tends to lead to the effects of radiotherapy. As seen here, it's not actually how it looks, but it's a very good demonstration of the fact that radiotherapy works by causing DNA damage. And then the reason that the side effects of radiotherapy take a while to manifest after it's been given is actually it doesn't really then properly kick in with the cellular death until the cells are trying to replicate with their damaged DNA. And now, what I'm going to focus on primarily today is the curative regimes of radiotherapy and the ones that are used in the neoadjuvant and adjuvant and curative setting. And the curative regimes of radiotherapy tend to be given over a long period of time. So we want to deliver a relatively high radiotherapy dose to the tissues. We express that in gray, which is the amount of joules per kilo deposited in a tissue. But we can't target it just to the cancer cells. We know that because we're getting the high energy X-ray beam coming in, it's going to be affecting all the normal tissues around it. So the kind of side effects that you get will very much depend on what area you're treating. So if you're treating a prostate, which is down in the pelvis, you'll be getting some of the radiotherapy going through the rectum and causing symptoms in the bowel, and you'll be getting some of the radiotherapy going through the bladder. And the way that we try and deliver radiotherapy is that we give it in very small doses from day to day until we build up to the whole full dose that we want to deliver. And the doses are based on us taking advantage of the 5 R's of radiobiology and the way that they differ between cancer cells and between normal cells. So what we do is we give a little bit of radiotherapy every single day, and it's usually Monday to Friday because that's when the radiotherapy departments are open, but we can deliver treatment over the weekends as well in emergencies. And the amount of radiation is delivered each and every day takes into account the way that the cancer cells behave versus the way that normal tissue behaves. And the 5 things that determine the effect of radiotherapy on the cells are these ones, the 5 R's of radiobiology. The first 4 were the ones that were initially found. That's reoxygenation, which is actually the presence of oxygen, or hypoxia as an alternate, very much determines the way in which the cancer responds. We know that hypoxic tumors seem to be a little bit more radioresistant, so we need oxygen around. And as cancer cells and tissues die off throughout radiotherapy treatment, there is a redistribution of the oxygen that's in there. Repopulation, which is of course that cells divide. So when you get cell death during radiotherapy treatment, in between those gaps that we get if we treat once a day, in between that time we're going to get some cell repopulation. Repair, which I'll come back to later as well, which is that when there is DNA damage, when there is cellular damage, in between those, the cells will repair themselves. There will be redistribution, and finally radiosensitivity, which is this innate, it was added later on, actually. It was not initially included into the, one of the R's of radiobiology, but as time went on, it was noticed that even taking these 4 things into account, there were certain cancers that appeared to respond very strongly to radiation therapy, whereas others didn't. And there's this innate radiosensitivity aspect of cancer cells that was introduced. And so taking these 5 R's of radiobiology into account, the fact that the way that normal tissue cells behave differently in this respect to the way that cancer cells do, particularly in repair, redistribution, repopulation, and radiosensitivity, means that we can take advantage of that difference to then plan delivering daily doses of radiotherapy and delivering such a dose in such a regime that the normal tissue is allowed to heal and repair itself, and we can avoid very long-term damage as much as possible whilst the cancer cells are eradicated. And that's essentially how radiotherapy works, and how the radiation regimes are decided, is that we try and work it in a way that we give, for the curative ones, a small dose of treatment every day to do that. Now, the way in which the beams are arranged is something that has not developed that recently, but which is an important part of demonstrating how radiotherapy works and the way in which it's developed over time, and the way that we've worked out how to use it over time. So I thought that this would be quite a good demonstration of the idea of the high energy X-ray beam coming in from the outside world, passing through the patient and depositing its energy. So what this shows is this shows 3 different ways of focusing on multiple high energy X-ray beams to treat a prostate. So if you think about the fact that this is somewhere in your pelvis, so you've got, there we go, that's the pubic symphysis out in front, and you've got the 2 hips out here. And what you can see here is that these are different ways in which you can arrange the high energy X-ray beams to come in from the outside world and deposit high energy in the area that we want to treat. And the red is where there's lots of energy, and the blue is where there's less energy. And what you've got here is you've got 1 beam coming in from the outside world there, coming in from the back. And you've got 2 beams coming in from the side. It's quite a simple way of treating it that was still used in some kind of cancers, and is quite straightforward. But what that means is that actually there's a little bit of the energy being deposited in these normal bits of the patient that you want to have time to heal and repair. So, for example, the hips. And if you move upwards in front here, you'll have the bladder sitting above it, and you'll have the rectum behind as well. So all of those normal tissues are getting a little bit of radiotherapy, so they're going to get some toxicity, but actually where the beams meet is where you want to treat the cancer, and that's the prostate. So the very high energy deposition is the beams meeting is the prostate cancer. And actually in the last quite a few years now, what we've done is one of the ways in which we've optimized using radiotherapy for our patients is that we've moved towards more complicated beam arrangements. So, for example, here you can see that instead of having this 3-beam arrangement, I believe actually from the top of my head this is a 5-beam arrangement, but I need to double check. You've got multiple beams coming in from different areas. And instead of having this square of high energy deposition, that if you think about the fact that this is the prostate and the seminal vesicles coming out here, you've got this high energy square. So some of the areas around there are getting a high dose of radiotherapy as well. This is much more conformal, so it's much more getting closer to the shape of the prostate. You've not got a square of high energy. You're getting closer to what the prostate area is. You're not getting quite as much dose there to the hips, for example. And then here, this is VMAT, so this will be just the radiotherapy beam just moving in an arc around the patient as the patient goes through. And the beam itself will be changing shape as it moves around the patient and is very much focused on the prostate now. So actually, if you compare these ones, you are now getting this very, very high energy deposition on the prostate. So it's much more conformal to the area that you want to treat. There's not the square. Slight downside of this is that actually then everything is getting a low dose bath of radiotherapy exposure. So though you probably won't see as many high level toxicities there as you would, for example, in this one in the hips, where you're getting much more dose, what you do get is you get some radiotherapy to all the areas. And we know that there is no level, there's no threshold below which there is no risk to the normal tissues with radiotherapy. So it's balancing that. So these are three. So this is an example of the ways in which we've tried to modify radiotherapy over the years and make it more complex, is to try and work out beam arrangements that can help us deliver higher doses to the cancer that we want to treat and give lower doses to the normal tissues. And this is an example on prostate. Head and neck is actually a very common example as well, because we've got a lot of structures in the throat that we want to try and avoid. But it's trying to balance the fact that you want to kill the cancer with trying to spare the normal tissues. So that's a kind of history of how we've got up until now. And now we're coming to what's probably the main bit of the talk, which is in terms of how we are trying to optimize radiotherapy more recently. So up until now, as I say, a big aim has been on beam arrangements and trying to work out the best ways to deliver the dose and try and minimize toxicity. But actually, as our understanding of the way that cancer cells repair themselves and respond to radiotherapy has developed, we also have come to an understanding that actually the same fractionation regime does not fit all cancers. And I'll explain what I mean. Essentially, as I said, we give a small dose of radiation therapy every single day to cancers. And a lot of the radical curative cancer treatments that we have used in treating radiotherapy have delivered a dose of 2 gray every day as just a set dose. And the cancers get, the cancers and the tissues get 2 gray delivered every day and over a period of many, many weeks, until we build up to a total dose of something like 70, 74. That's the region of what we've got as curative doses. And that was a very standard regime for a very long period of time. That 2 gray per fraction is still something that's very commonly used by radiation oncologists to refer to a sort of a set baseline. But actually, we've come to understand that 2 gray per fraction is not necessarily the right dose for each cancer type. And there are certain cancer types which respond either better or the same way if we give high doses of radiation per fraction. And so actually there's been a movement, certainly in the last 6-7 years more, of whether there's certain cancer types where you can give shorter treatment regimes but higher dose per fraction, and looking at whether that is comparable to the longer treatment regimes. And of course, the benefit of that is that if you are a 75-year-old man and you have prostate cancer, coming to have radiotherapy every day for 7.5 weeks, Mondays to Fridays. It's quite a long treatment period. It's quite difficult on you as the patient to come and do that every single day. It's quite tiring with all the side effects, but it's actually also a big strain on the health services. So as we have an aging population, as we learn to deal better with other aspects of disease like diabetes and infections, which means that people are living longer. Cancer is a disease of the elderly, primarily, not always, but most of the time. And as we have an aging population, we find that actually there's a lot of patients coming through, and it puts a great strain when you have these very long fractionation schedules that patients are receiving. So what I thought I would do is move on to just talk about two big trials, one that was published in 2016 and one that was actually only published last year, that focus on two very, very common cancer types and demonstrate a good example of this. There are others, but this is the most obvious ones. And the first one is the CHIP trial. And the CHIP trial, as I say, focuses on prostate cancer. And just to give a little bit of background, because now we have quite a range of audience, prostate cancer is very, very common. And in the UK, it's the most common cancer in males. And actually, it's so common that when you look at the incidence of new cases in a year, it averages out to there being more than 130 new cases of prostate cancer per day in the UK. And that's across different ranges. And actually, prostate cancer is managed in many, many different ways, with hormones, with surgery, with radiotherapy, with chemotherapy. But about 30% of patients with prostate cancer are going to have radiotherapy as part of their primary cancer treatment. And again, what we talked about is that's a very large number of patients. And in fact, the standard radiotherapy regime up until about 5 years ago now was that those patients will have approximately 7.5 weeks of treatment. So for 7.5 weeks, they would come to your cancer center every single day, Monday to Friday, to have their treatment. They don't need to stay there. They're there for a couple of hours, but that's quite a lot of strain on people. And especially where I currently work in Brighton, we cover a very large area, so people can be traveling for hours and hours every single day for a large number of weeks to try and get this treatment. So it's quite difficult on them. And so what the CHIP trial did is it used, let's try it, there we go. It was an international multi-center randomized phase 3 trial. So just as a reminder, phase 1, we're looking at the safety and tolerabilities. Phase 2 is it working? Phase 3 is comparing it to the current standard of care of men with localized prostate cancer. So it was just in the prostate, hadn't gone to any of the lymph nodes, which is a very common area of spread, and hadn't metastasized. And they compared 3 different fractionation regimes. The 74 gray and 37 fractions, which is your very standard regime that I mentioned at the beginning, and the whole 2 gray per fraction idea, versus 60 gray and 20 fractions. That's it's a huge difference. That's actually just 4 weeks, so still quite a long period of time to have somebody coming every single day, given the kind of side effects that you get, but much better than coming for many more weeks than that, versus 57 gray in 19 fractions, so just 1 less from 60 gray. And so obviously this is moving from this whole 2 gray per fraction idea to, in prostate cancer, having 3 gray per fraction. And the question is, does it work just as well? And what are the side effects like in terms of comparing it? So is it overall comparable? Can we use this for patients? Because if we can, then it means that patients can come a lot less to the hospital. And it also means that actually it frees up that radiotherapy machine so we can treat more patients. It can take some of the stress and strain off of the health services as well. So overall, 3,216 patients were assigned in this trial. And actually, looking at biochemical or clinical failure-free survival here on A, this is the direct result of the CHIP trial, versus looking at overall survival. What they looked at was they looked for non-inferiority. And the first one here, comparing 60 gray versus 74 gray, shows that actually hazard ratio is 0.84. So this is 74 gray, there is the blue line, 60 gray there is the red dashed line, and then 57 gray here is the little line here, the purpley line that's coming down. And what they found was that they could state that 60 gray given in 20 fractions, so 4 weeks of treatment, was not inferior to the standard fractionation regime that we were using, the 674 gray. They couldn't clearly state that for the 57 gray. It didn't meet their preset criteria for non-inferiority, but they could say that for the 60 gray, and we can see that actually the two are then comparable. The other thing that we're looking at, obviously, is what are the side effects. And the main effects from radiotherapy on the prostate, I already mentioned before, is to do with what's there primarily. The majority of radiotherapy side effects, except tiredness, which is just common to every single patient that gets radiotherapy, is to do with the area that you're treating. So if you're treating the prostate, they get a red area of skin down in the pelvis. And they get side effects from the bladder and the bowel because those are the other areas nearby that you're giving treatment to. And those are the main important things that we look at as well. And what this shows is, it shows, again, blue here is the 74 gray, red is the 60 gray, and purple is the 57 gray. It talks about, what it looked at was bowel adverse events. Grade 1 to 3 is how severe they were. So grade 1 is the least severe, it's not really bothering the patient very much, and grade 3 is actually quite severe, and sometimes patients needing hospitalizations and things like that, but it's quite bad. And patients with bladder events. And what they found was that actually bladder was, again, comparable. The side effects came on a bit earlier, and I already touched upon this before, but because there is a low dose of radiotherapy delivered every single day to the cancer, coming to a total, and because it takes a little bit of time for the effects of radiotherapy to kick in, what that means is that actually patients don't notice any side effects when they start radiotherapy. And what I tend to warn my patients about is that normally they won't notice anything for the first 2 weeks or so for these regimes, and then the side effects are going to start to kick in, and they're actually at their worst in the 2 weeks after radiotherapy has finished before they start to get better. And what they found was that for these shorter regimes, you had an earlier peak than you did for the longer regime for bladder, but they were about comparable. For bowel, there were a bit more people had them, so they were a bit more noticeable for bowel that you had the side effects. And these are just the grade 1s up here. So more severe side effects are down here. They remain not as common. But actually, long term, they were comparable. So these are very much the acute side effects, and these are miserable for patients, but they get through. But what we obviously really care about the most is, in the long term, how much is function affected. And actually what they found was that for the two that we were interested in, the 60 gray and the 74 gray, though the short-term side effects peaked earlier and they were more common in terms of bowel toxicity in the hypofractionated regimes, the shorter regimes, in the long term they were comparable. And this trial came out, the phase 3 results got published in 2016, and what it's led to is it's led to a change in practice. So since that time, if you have patients where you're not treating the nodes, instead of giving them the 74 gray and 37 fractionation schedule, you give them only 4 weeks of treatment, and that makes a big difference to patients. So that's the CHIP trial from prostate, and I think that actually demonstrates that very well, that idea of trying to use our understanding of radiobiology and of the behavior of cancer cells versus normal tissues to try and take some pressure off the patients and off the health services. And the next one I'm going to talk about, which demonstrates that quite well, is the Fast Forward trial, which looks at breast cancer. And again, breast cancer, the reason this is such an important trial is it's a very, very common cancer. It's the most common cancer in the UK. It comes to approximately 150 new cases per day, and 63% of patients that are diagnosed with breast cancer are going to have radiotherapy as part of their primary standard treatment. So again, that's a large number of patients. And the standard regime that these patients got up until last year was 40 gray in 15 fractions. So they came over 3 weeks, Monday to Friday, and the total dose came up to 40 gray. This actually is already an adjustment. I remember I talked about the idea that the initial way that we did things was we gave 2 gray per fraction for everyone. So that's already an adjustment. It previously was 50 gray and 25 fractions. So already we've gone from giving them 5 weeks of treatment to giving them 3 weeks of treatment. And the question from the fast forward trial was, can we give just a week of treatment? Is that comparable? And is that, what is the toxicity? Is that comparable in terms of how well it works? And is it comparable in terms of the long-term impact? Because these patients, again, this is curative treatment they've had surgery, and radiotherapy to the breast is given after they've had surgery. And what it does is it basically sterilizes the area and makes sure that once the cancer has been removed, if there's any small cancer cells that are left behind in the breast, those receive a high dose of radiotherapy and they are eradicated, and is given with the aim of decreasing the chance of having primarily a local regional cancer recurrence. So primarily it's there to stop the cancer coming back in the breast, and that's the main aim of it. And it was a multi-center phase 3 randomized trial, just UK based this time as opposed to the CHIP trial, looking at invasive carcinoma of the breast. And it compared your standard fractionation regime of 40 gray and 15 fractions to 27 gray and 5 fractions to 26 gray and 5 fractions. And that's radiobiologically, they are slightly different doses. So it's not that you're giving a lower dose. Actually, the way that it translates the cancer cell is comparable dose to this one. It was 4,096 patients. And actually, the crucial thing about this trial is the timing of it getting published. It got published at quite an important bit of oncological management. It came out in April 2020. So the trial of looking at whether patients could come to hospital less and get the same benefit from their treatment got published bang in the middle of the very first wave of COVID, at a time when all in the UK, certainly, all the oncologists were quite worried about bringing their cancer patients to hospital because there was a huge pandemic going on. Everyone was being asked to stay home, and you had to balance as an oncologist the risk to your patient who was already having cancer treatment coming to a hospital every single day in terms of what their risk was of getting COVID and what the benefit of doing that would be to their cancer. So we were having to weigh that up already. And this is when it got published in the middle of all that. And the results were that the 26 gray in 5 fractions and the 27 gray in 5 fractions, again, were non-inferior to the 40 gray in 15 fractions. So this is a graph showing ipsilateral breast tumor relapse, which is the primary endpoint that we're interested in. It's the main thing that we're looking at is it coming back in that area, because that's the main aim of the treatment for this. And actually, looking at the hazard ratios here, there was non-inferiority of both hypofractionated regimes. So 1 week of treatment did not have worse outcomes of the cancer coming back for our patients compared to 3 weeks of treatments, which was huge at a time when we were trying to minimize the amount of time that patients were coming to hospital. However, what they did find was that the toxicity in the 27 gray and 5 fractions was worse compared to the 26 gray and 5 fractions. So as a result of this trial, now published just over a year ago, in the last year, patients who have been, it was 5-year outcome, so there'll be more coming through, but actually patients who have just localized breast cancer that's been removed, that don't need treatments to the local regional lymph nodes, are now getting 1 week of radiotherapy instead of 3 weeks of radiotherapy. And again, remember I talked about the fact that toxicity is very much dependent on where in the body you're treating. So with breast, the things that we look at are breast shrinkage, change in shape, effects on the skin, and then effects on the organs underneath. So things like on the left-hand side, you have the heart sitting right underneath the breast, and that's something important that we look at as well. So that actually, again, was another change in practice a year ago. And it's not the only trial that came out at that time that's resulted in that showed that hypofractionation is something that we can use, that then became rapidly used because of COVID as well as everything else. But those, I think, are the main 2 examples I wanted to use because they're the 2 huge tumor types that everyone knows about and are very, very common. Everyone knows about prostate cancer and breast cancer. And actually, in the last 6 years, the amount of treatment that we give patients in terms of dose will be comparable, but in terms of fractionation, there's been these move towards taking pressure off patients and off the health service. So I'm going to move away from the hyperfractionated treatment now, and just very, very briefly touch upon the idea of de-escalation. So again, we talked about the fact that there was very much a tendency to give everybody these high doses of 2 gray per fraction across all cancer types. But as our understanding of the way that cancers behave grows, there are some types of patients where we're saying, okay, well, actually this treatment regime that we're currently using is associated with a lot of toxicity. It's causing people a lot of problems, especially in the long term. Are there certain groups of patients that may not need to have quite as much treatment and will do just fine? And a big area of that, and one where we're still looking at things, is head and neck cancer. So head and neck cancer is the 8th most common cancer in the UK. And when it is locally advanced, one of the main ways of treating it to try and eradicate it is with radiotherapy, with chemoradiotherapy. But I already touched upon this. There's a lot of things in the throat that get toxicity when you give radiation therapy. So the high-energy X-ray beams come in from the outside. They're concentrated on this area of the neck, which is the nasopharyngeal is up here, but in terms of throat cancers, laryngeal and oropharynx, which is a vast majority of them, you're treating this area. And as I said, the side effects are associated with what's around there. And what you have there is you've got your swallowing, your mucosa, you've got your salivary glands, you've got your spinal cord. There's a lot of very important structures. And as our cure rates get better for these patients and as they live longer, actually a lot of the time what we find is that they have to live longer with a lot of potential toxicities and side effects, and primarily its impact on things like swallowing, because you're radiating the area of swallow there, causing them a lot of irritation, discomfort, and in the long term that can have an impact on swallowing. And oropharyngeal cancers, things like tonsil, the back of the tongue, actually a lot of those cancers are associated with a virus, with the HPV virus, human papilloma virus. People know this virus as being associated primarily with cervical cancer, but actually it's also one of it's one of the causative things associated with throat cancer, with oropharyngeal cancer. And the patient population that we're seeing in head and neck clinics is changing. So about 20 years ago, the majority of patients that came to your head and neck clinic would be very elderly gentlemen, and they had spent pretty much their entire life having a fair amount of smoking, a lot of cigarettes, and alcohol, which are the 2 other risk factors for head and neck cancer. So many years of drinking and smoking would lead to having the head and neck cancers. And over time, we found that the incidence of HPV positive cancers has been increasing. And this is a different patient population, no smoking, no drinking, or very little, but the cancer is associated with this virus. And actually now it's reached 73% of the oropharyngeal cancers in Europe. And we know that radiotherapy is highly toxic. And the question then is, can we personalize treatment to patients? Because primarily, HPV cancers have a better prognosis. They respond better to radiotherapy and chemoradiotherapy. The patients do better. And if the patients are going to do better, is there a way that we can try and help them do even better by avoiding these very long-term toxicities that we are seeing in our head and neck patients when we complete treatment? So there's been multiple ways of trying to do that, and things like replacing the cisplatin, which is given alongside radiotherapy to make it work better, to see if you can get less toxicity, and that's not shown that we can de-escalate. But this trial, the PATHOS trial, is ongoing at the moment. No results yet, but it's something that is trying to look at that specifically. It's a multi-center phase 3 randomized controlled trial, and it's for HPV positive oropharyngeal cancers. And the main thing it's looking at is the tumor resectable via the transoral approach? So can they go in and just take it away through the mouth? And then the adjuvant treatment is then looking at randomization of the dose or chemotherapy. So it's looking at if patients are low risk, medium risk, or high risk, what they would normally get. So, for example, the intermediate risk patients would normally get 60 gray and 30 fractions to try and sterilize that area. And it's looking at, in these patients, can we randomize them to get 50 gray and 25 fractions? And will that work just as well in terms of helping keep away long-term recurrence of the tumor without having as much toxicity? And also in high-risk patients, it's saying, can we omit chemotherapy? So at the moment in high-risk patients, what happens is they get cisplatin. They get it either once every 3 weeks or they get it every week. And cisplatin increases the response of over 5 years. It improves things by about 6.5%. We know that from previous trials. So high-risk patients, we offer it to them. However, it makes things worse in terms of toxicity. Patients struggle more if they're having chemotherapy alongside the radiotherapy because it radiosensitizes, it makes the toxicities more. So again, it's looking at, can we then, can we try and omit that? Will it be comparable? So the results obviously aren't published yet, but they'll be coming through in the next couple of years in its current ongoing trial. Again, working at whether we can make things better for our patients, whether there's patient populations where we can decrease that. This isn't the only trial that's doing that. There's also an ongoing trial in anal cancer looking at different regimes, but obviously this is a very big area because it's a very toxic treatment that we give. And then the final area that I'm going to talk about, which touches upon what my main area of research interest, is the idea of radiosensitization. So just bringing things right back to the beginning of the talk when I talked about the use of radiobiology, a very important part of that is repair. If radiotherapy causes cell death by damaging the DNA and the cells then try and repair themselves, can we target that? Can we try and target that repair mechanism and stop the cells from repairing themselves and radiosensitize them? And that's something that's been looked at for a long time. So they've used a number of different DNA damage repair inhibitors to try and look into this, and there's currently trials ongoing. But the particular area that I'm going to bring in, because sorry, this is just an example of the way in which DNA repairs itself. So the main problems that cause cell death after radiotherapy is going to be double-stranded DNA breaks. And they can arise either because the radiotherapy causes a straight double-stranded DNA break, or they can arise because you've got two single-stranded DNA breaks which are in close proximity to each other. And there's two different repair pathways that are commonly used for double-stranded DNA break repair, which is homologous recombination repair, which is only used in one part of the cell cycle. It takes quite a long time, and it requires cystic chromatids, so it's not as commonly used. And this common non-homologous end joining pathway, which is very quick, not very accurate, but can work at any point of the cell cycle. And the question is, can we target it? And the particular area of interest that I was going to bring in is that there are some viruses, adenoviruses in this particular example, they are DNA viruses, and they replicate inside the cell nucleus, and they have actually developed ways in which they can inhibit the cellular DNA damage repair mechanism. And it's thought that they do this because otherwise, when they're replicating, the cellular DNA damage repair mechanism recognizes the replicating virus as being cellular broken DNA, and it tries to repair it, and it joins the genomes end to end, and the viruses can't replicate because they're being recognized and being repaired. So actually, this is an example of all the various ways in which adenoviruses can target the DNA damage response. There's many different serotypes, and you can see that actually there are some areas, the DNA damage repair mechanisms, which are targeted by multiple different serotypes of adenovirus, and in particular, the one that's targeted by everything studied is non-homologous end joining. And going back, this is the one I said was very quick, very easy to use, and can be used in any aspect of the cell cycle. So this primary double-stranded DNA repair mechanism, which is pretty much used by the cell the majority of the time, is the one that is most targeted by viruses. And the question then is, can oncolytic adenoviruses, adenoviruses that specifically target cancer cells, be given alongside radiotherapy to try and cause a very much targeted radiosensitization of the tumor cells? So just very briefly, clicking through this, this is the area that I concentrated on. there are certain oncolytic adenoviruses. This is something called an adenotussirev that we can see actually is increased by the delivery of radiation, which is excellent. It replicates better when you give it radiotherapy. And what that results in is when you do an in vivo study, it was a mouse study, when you add virus to radiation, you actually do get this increase in survival. This was the very, very quick pilot trial in mice. But what is currently going on, which is the main aspect of this, is that there is currently a trial that's looking at using chemoradiation in rectal cancer with an oncolytic adenovirus to see whether we can try and do targeted radiosensitization. And this is just a phase 1 trial at the moment. It's only just started, but in terms of thinking about different ways in which we're trying to target cancer cells and trying to improve cell death whilst optimizing things for the patients, one of the ways that we're trying to target cancer cells is radiosensitization. There's multiple different ways of doing that, but one of the ways that I thought I would mention today is oncolytic adenoviruses, and this is 50 grain, 25 fractions with concurrent capecitabine, which is your standard regime, but using a radiosensitizer alongside it. And radiosensitization is something that we've as radiation oncologists, we've been working towards for a very long period of time, with variable success. Some radiosensitizers are in very common use, so chemotherapeutic drugs, things like bladder cancer and head and neck cancer are already being treated with radiosensitizers alongside chemotherapeutics, but they cause a lot of toxicity. And how can we do this targeted radiosensitization to try and avoid that is one of the questions that we're asking at the moment. So in conclusion, radiotherapy curative regimes are associated with quite long fractionation schedules, and there are a number of associated toxicities that come alongside this because we cannot avoid treating normal tissue by the nature of the way that external beam radiation works. And a lot of what we're doing at the moment, a lot of the big trials that are being done at the moment are there certain patient populations, are there certain tumor types where we can get the same level of benefit from the treatment, but with less stress. And that's not just less stress on the patient, that's also less stress in the health services as the amount of cancer increases. There's things I haven't touched upon. I'm aware of that because radiotherapy is a huge area. I'm happy to try and answer any questions of this, but there's certain other areas of development, such as improving the imaging techniques. When we plan radiotherapy using MRI, for example, to try and get better delineation of structures, using SPRT, which is very, very high doses of radiation focused on very small areas. And obviously everyone knows about proton therapy, which is using very high energy particles which deposit their energy just in one small area, so they can be used to treat cancers that are very close to critical structures like the spinal cord or the brainstem. But there's a bit too much to talk about all in 40 minutes. So this is just my references, and I use quite a number of images there. Thank you very much. I will hopefully have some questions.
All right, thank you so much. All right, so it was a really great talk, and we have a question from Khatija Abubakar Bobo. Thank you for the presentation. What is standard daily dosage, time-wise, minute per hour, and does the daily dose depends on the size of tumor and body density of the patients? Thank you. Can you see the questions on the Q&A? Yeah.
I can't see the questions. Hang on. Let me try and
It's on their right side. Yeah.
I don't think I've got that view, but nope, I cannot see the questions, but I can try and answer that. So does the it doesn't depend on the body habitus of the patient, the fractionation schedules. For palliative treatments where we are aiming to control, not cure, it would actually depend on the well-being of the patient and what their prognosis is. So I'll answer that in different ways. So for curative regimes, we would have a standard regime for each tumor type, pretty much, and we'd adjust it to certain pathological features. But actually, where the patient themselves becomes much more important is in palliative regimes, because we are being practical. We're trying to help the patient. We're trying to minimize toxicity. And there are a number of different palliative regimes which are given, going from a single fraction, usually to giving a week to 2 weeks. So if somebody just has some pain and we just want to try and help with the pain, we give them a single fraction. And if somebody is quite frail, and we know that radiotherapy is going to tire them out, we would usually just give them a single fraction. We bring them in and just give them a single zap of radiotherapy to the area that we want to treat. Whereas somebody is quite active and has a fairly sizable tumor there that we want to try and get control of, we might give longer palliative regimes of, for example, 5 fractions is very, very commonly used if you've got a bulky tumor there, and if you've got somebody who's relatively active, still very well tolerated, but better so than the single, but slightly less so than the single A grade. So the question of whether fractionation schedules depend on the patient, for palliative, yes. That's because for palliative radiotherapy, we're being very practical and we're trying to be kind. We're trying to help patients. We don't want to put them through very long, very toxic regimes. We just want to try and help with what's going on. The question of body habitus, usually no, we wouldn't be adjusting radiotherapy regimes to that, but we would be adjusting radiotherapy regimes to different tumor types. And that's come more and more. That didn't used to be the case. So it used to be most tumor types used to get 2 gray per fraction, as I discussed earlier. But now actually, as we're understanding more, we're adjusting it depending on cancer type. So we know that, for example, head and neck responds to smaller gray per fraction, whereas things like prostate and breast, because of the way that they behave in response to radiotherapy, respond quite well to having hyperfractionated treatments, having quite a large dose comparatively. So having something like 3 gray, and actually the one I didn't talk about, which is rectal cancer, which is the Rapido trial, which also came about a year ago. That's gone from the standard regime, which is still used in some cases, is using that over a period of 5 weeks. It's gone to just 1 week, 25 and 5. So that's 5 gray per fraction over just a period of 1 week. So depending on the tumor type, you do get very different doses. Was that the whole question? Remind me, sorry, because I can't see it.
Yeah, I think so. Yeah, so I'm just curious. So, is the regimes aim to be applied to children as well? Because I don't think we mentioned about children.
We did not talk about pediatric cancers. Pediatric cancer research is quite a large topic, and I've mainly focused on the main tumor types. It's a really good question. It is one I'd have to look at, but children actually is more where, because they present with different tumor types, it's more one where potentially things like proton therapy might be relevant, because you're trying to preserve critical structures. But I'm not able to confidently answer what the fractionation regimes in pediatric tumors are.
Okay. So are there any criteria for selecting patients that are suitable for radiotherapy?
Patients that are suitable for radiotherapy? Yeah, so there are. So different tumor types have different levels of radiosensitivity.
Okay.
And but there's also different types of radiotherapy. So there are set criteria for patients of whether they should receive neoadjuvant radiotherapy. So radiotherapy is going to be aimed to shrink the cancer and try and improve surgical outcomes. Different criteria for radical radiotherapy, like using head and neck and prostate, which is where you're trying to get rid of the cancer, and also for adjuvant radiotherapy for patients who have breast cancer. And there are many, many trials that are done to work out who the patients are that we can give that to, and also who the patients are that we can emit that from. So, for example, in breast cancer, there is now guidance on patients who have certain very small cancers, very low-grade cancers, and who also are older. So actually, we don't expect their lifespan just naturally to be so long that the cancer is likely to come back in that period of time, where you might be able to emit radiotherapy safely and not give it. In terms of palliative patients, the criteria of whether you give radiotherapy or not is there a clear area of cancer that's causing problems? and how long does the patient have? What is the prognosis? Because radiotherapy takes a number of weeks to have full effect. So you want to look and make sure that you're not bringing a patient to the hospital to have radiotherapy treatment if they don't have very long left, because they might not get that benefit, but they might get all the side effects. So it very much depends on the tumor type and why you're using it. But yes, there's many trials looking at what the criteria are, and we do have set criteria for each tumor type. And
Right.
it's actually,
So
what's interesting, sorry, I'm getting carried away. What's quite interesting is also now some metastatic patients are getting quite high radiation regimes and things like prostate, because we know that we have a very good prognosis.
All right. I have another question from Dr. Gayatri. Is there an alternative radiosensitizer which has less toxicity and can be used with radiotherapy instead of cytotoxic chemotherapeutic drugs? I think you mentioned about adenovirus, oncolytic virus. So is there any? Yeah.
So that's one of the big questions at the moment, and what they're primarily focusing on is I mentioned as one very quickly adenoviruses, but what they're trying to look at is whether they can use inhibitors of the DNA damage response. So, for example, ATR inhibitors, ATM inhibitors, things like that. So just combining it with that, and an alternative to radiosensitization, which is obviously huge, but we didn't really have time to touch upon today, is immunotherapy. And that's kind of less an idea of radiosensitization and more an idea of, can we use immunotherapy combined with radiotherapy to prime the immune system, so that if you treat one area of the cancer with radiotherapy, you can get this thing called an abscopal effect, where you prime the immune system and actually other areas of cancer not treated by radiotherapy are then attacked by immune cells. So there's lots of the radiosensitizers that mostly we're focusing on nowadays are the DNA damage repair inhibitors, but also the other aspect that we didn't really have time to talk about is that immunotherapy can be toxic, but it has slightly different toxicities, but is something else is being used alongside radiotherapy to try and work out if we can make it work better.
All right, great. Since you're talking about immunotherapy, there's one question here. What do you think of the gap which need to be addressed for the use of bispecific T-cell engager, BiTEs, coded oncolytic viruses in the clinics? How does the timing of institutions oncolytic relative to the time of radiotherapy affect the effectiveness of the therapy? So there are two questions here.
Wow, that is an amazing question, and would probably make quite a good thesis, actually, I think. So there was quite a lot of different aspects to that question. So it was bispecific T-cell engagers in the timing to radiotherapy. Was that sorry, I feel I need to see that one, and I don't know how to look at the questions, I'm afraid. Apologies.
Okay, can you see on the right bottom, did you see participants and chat? Maybe you have to escape sharing.
I think I might have to stop sharing. I can see chat. Yes. Okay, does the current radio sorry, so which question was this one?
This is question 4 from Dr. Allen.
Okay.
What do you think of the gap which need to be addressed for the use of BiTEs? It seems like it's a combination of your work and what's that guy?
Yes, and the work of my lab. I actually, for some reason, can't see that one.
Okay.
But in terms of timing radiotherapy with BiTEs is something that we have actually touched upon in terms of oncolytic viruses and BiTEs and radiotherapy, and the way that the two would work together. And it's a very, very good question. I'm sorry that I can't quite see it. But
let me send the questions to you. Maybe.
Do you want to send it to me? Thanks. Just so I can, because I feel.
Okay. So
okay.
Look at the chat.
Perfect. Thank you. What do you think of the gap which needs to be addressed for the use of bispecific T-cell engagers coded oncolytic viruses in the clinic? How does the timing of institution of oncolytic virus relative to the time of radiotherapy affect the effect of the therapy? So yeah, that's a really good question, and one that we discussed before at a previous talk, not this one, but in terms of the fact that obviously because of the way that radiotherapy works, because it works with a bit of a delayed reaction, it causes the cell damage, and then the cells try and replicate, and they only die off later. And because radiotherapy actually, the side effects kick in 2 weeks in, it doesn't really properly work until weeks afterwards. So post radiotherapy treatment scans are done 3 months after you finish the treatment. The idea of when you deliver bites and oncolytic virus associated bites is a really, really good one, because it has to be at a time when you're getting the most inflammation and irritation, and it really, I think really the best way to do it would be to do a trial of working out giving it alongside maybe weekly radiotherapy versus before. But I don't think there's a clear-cut answer to that one. I think something that we did touch upon before was the idea of, for example, if you were doing surgery and you're doing localized treatment, whether you can work out a way to deliver the bite locally during surgery. But then the problem comes in is the fact that radiotherapy is often delivered many weeks after surgery, because the patient has to recover. You have to do the planning scan to work out the physics of the beam arrangement and then treat. And you have to try and work out a way that you've got a virus that's still replicating and is still delivering that at the time when it kicks in. So I think it does very much depend on whether they're replicating or non-replicating oncolytic viruses in terms of what the timing that you've got is going to be for delivery of the bites. But there's definitely a gap there. I think we're trying to fill it from Professor Seymour's lab, certainly. And I know that there is some very interesting research that is happening specifically in that area. But I don't think that I can answer that question very well, because there is still a gap.
Well, I think I should get Josh to present the bites.
I think you should, yes, or Mr. Ball, who's currently looking at bites as well.
Yeah, I think there's a last question that's sent to you. Do you have reservations on possibility of a long-time effect of oncolytic adenovirus, such as accumulations inducing tumorigenesis instead of aiming at curing normal cell cytotoxicity?
That's an interesting one. So we wouldn't expect the oncolytic adenovirus to have a high tumorigenesis cause. The thing is, radiotherapy itself, also one of the things that we consent patients for when we consent them for curative radiotherapy is that because we cause damage to the normal tissues as well as the cancer cells, one of the risks from just giving radiotherapy alone is that many years down the line, there may be a secondary cancer which would not have come about had we not given radiotherapy. So I think, unfortunately, we already have that as a risk. We're inducing tumorigenesis. That's something that radiotherapy already has a risk of doing. In terms of the possibilities of long-term effects of oncolytic adenoviruses, at the moment, we know that it goes to tumor cells, but the good thing about them being oncolytic is that actually they do specifically target tumor cells. So in terms of accumulation in normal tissues, the trial data that we have till now does show that they're oncolytic because they specifically target cells. Now, in terms of whether they induce tumorigenesis, that's something that radiotherapy unfortunately already does. I think time will tell in terms of whether there's any normal tissue toxicity which may exacerbate that. But certainly it's not something that we would expect, given that they do target cancer cells specifically. However, the purpose of trials is to test our theories and make sure that we don't make assumptions.
Yeah, I think you talk about a lot of combinations therapy like including radiotherapy plus oncolytic virus, and then radiotherapy with immunotherapy. I think that's the way forward from now on, because like we know the traditional single treatments will not work, and we need to have that. I think one of the challenge is like when you have oncolytic viruses that being introduced is, people are skeptical.
Oh,
And,
yes.
and immunotherapy is really expensive at the moment. And well, we really hope that there's an alternative treatments that we can use for treatment of cancer. And we know cancer is one of the like killing diseases in the world. And hopefully we can solve this problem soon. Yeah. All right. I think that's all the questions that are being posted in the Q&A sessions. I hope we have answered all the questions from the participants. And thank you again to Dr.Tzveta Pokrovska. I hope I pronounced your key. I never pronounced your name.
Thank you so much.
Thank you so much for accepting my invitations to come to give a talk to our Malaysian populations or participants about radiotherapy. And it really gives us a really good insight about radiotherapy. We know that radiotherapy is something that we use for treatment of cancer, but in detail, like all the grades and things, the regimens, and we have no idea until you give a really good talk today. Thank you so much. Thank you.
Thank you. Have a good day.
You too. You have a good rest tonight, today, after a long on-call week. Thank you everyone for joining our Canres. That's it for our Canres webinar for today. Thank you so much.
Thank you.
Thank you.
Thank you. Nina can stop record.